Thanks for joining this evening. My name is Sid. I'm one of the leads from I'm the Bleep, and I'm here to chair this session in the careers talks. Thanks everyone for joining. Tonight we've got Kim. Kim has kindly agreed to give up her time to give us a talk on surgical training, core surgery, and her further training pathway. Kim, I'm just going to invite you to the stage now. So an option should come up on your screen to join. And guys, just to say during this talk, if anyone's got any questions, just put it in the chat box. And what we'll do is at the end, we'll go through all the questions. Okay guys, sorry, just bear with us 2 seconds. Kim's just having an issue with her connection. No, there's not going to be any sound yet. I'm just waiting for Kim to rejoin the talk, and then she'll be able to share her slides. Just bear with us 2 seconds. Antonio has to. Does it sound like a robot voice? I'm not too sure on that one. Hi, Kim.
Hello, hi. Nice to meet everybody for the first time.
Nice to meet you. Thank you so much for doing this.
No problem and pleasure. It still sounds like a robot voice from my end.
Really?
I can't really hear you very well.
Okay, that might just
Yes,
be
I don't know whether it's my
I think
computer
that's
or...
probably just my computer.
Yes.
Okay, Antonio, can you hear Kim normally, or is it just me that sounds odd?
Can everybody hear me all right?
Just
Okay,
me.
good
Okay,
stuff.
cool. All right, that's not an issue then. Oh, okay, guys. Kim, if you see at the bottom of your screen, there'll be an option to present now.
Yes,
then you
I'll
go to-
just get my slide on. Let's see.
Yeah, sorry guys. I think that's my computer audio, which is acting up. Perfect. Okay. I'm gonna turn my microphone and camera off, and I'll come back on at the end for questions.
Is that showing on full screen?
Yeah, we can see.
Okay, good stuff. Welcome to tonight's Mind the Bleep career webinar series. My name is Kim, and I will be talking about core surgical training, or the latest known improving surgical training for the last few years. Just for the content tonight, we'll be talking about why considering surgical training and why not, your good day and bad day in surgical training for the first 2 years, and the training structure, the application and selection processes, and how to prepare a medical student or a junior doctor before entering your specialty training. Then we will have a Q&A if anybody's got any questions. So, a famous quote from Sir Astley Cooper: a surgeon must have a hawk's eye, a lion's heart, and a woman's hand. So true until you enter first year of your surgical training. Then again, my supervisor once told me that anybody can be a surgeon, you can train a monkey to do surgery. So, which the quote is true, I don't know. Why do the surgical training and why not? So this a few points to consider, my personal experiences. Training will look going into outpatient clinic, shadowing your supervisor or your consultant surgeon on a Monday, then going to theatre, either elective list or emergency list on a Tuesday or Wednesday, and then going on call in some of these days to see patients in A&E, GP referrals, ward referrals, depending on who, which part of the job between your registrars. So you're basically a house officer, what they traditionally call, or a junior surgical trainee. You might be expected to attend trauma course as well, going down to A&E and see some exciting trauma cases, or you might be called by your FY doctors to attend some really unwell surgeons on the ward. Ward round is your bread and butter.
I'm sorry to interrupt. Your slides, we're just seeing the first slide rather than...
Right, okay. So
there you go, I can see the second slide now.
Are you seeing the second slide?
So I can see the Y CST/IST. Why not? Question mark. Okay. Now I'm seeing content, the second slide. So,
shall I so
letting you just do a slideshow, then you may have to keep it as such and just manually.
Yeah, is that better? At least you can see the content.
Exactly.
Okay.
Yeah. Thank you.
Yeah. So, spoken about. So basically, these are the content that we'll be going through in this 1 hour, and then this was the quote I was mentioning about, and then a typical of how surgical training is like for the first 2 years. Depending on your department, you might be asked to attend MDT and chip in on certain patients that you've seen throughout the week. And so it's a pretty exciting rota if you look at it, but it varies between different trusts. How much training in each aspect get in the first 2 years. Interest in anatomy is obviously a huge topic. You can't have a surgeon who wouldn't appreciate anatomy because that's what you are working with mostly in theatre. Then I put this next point just because there was once when I was in theatre assisting in an above knee amputation, then there was this nursing student who went faintish looking at the leg coming off the patient, and then I realized that it's not for granted that everybody can witness all the gruesome things that we do in theatre. So this is an aspect that somebody who is interested or considering surgery should be thinking about before going into training. How much among the spectrum can you tolerate, or are you willing to undergo to see in theatre for you to become a a surgeon. Demand for physical and mental strength in theatre is something that has been on my mind for a while. I'm not by any means a person, but I've picked up strengthening training recently, just because I don't want to be, somebody who's end up with really achy muscles by the end of my training. And imagine you have to do this day by day until you are age 55, 60. It is huge demand for both mental and physical strength. I have had really experienced surgeon who went in theatre at 10 and came out 4 a.m. in the morning for one huge case. Basically a marathon. Fear for unknown and adversity is something that, is constantly our bread and butter as, medicine generally, but especially so in surgery, because everything we do is based on our decision on the spot in that moment with the available information that we have. And, it's stressful. It's just inevitably stressful on days that you are in theatre making decisions, whether to take patients into theatre, or even when you're seeing patients with complications post-surgery in your outpatient clinic. It's something that you have to be mentally prepared for before you even consider being a surgical trainee or eventually a consultant. So what is a good day like for a surgical trainee? Basically, one of the best days for me would be if I were given the opportunity to go into theatre and to work on, simple cases, not overly complex cancer cases that big shot consultants work on, but something like appendectomy or even skin lesions. Amputation with a tool, that I get to do most of the procedures, and 2 or 3 of this procedure a day would make my day. Outside theatre, good learning opportunities, some consultants who's willing to spend their time on you teaching rather than focusing most of their attention to the patient, and this would definitely make your day a really fruitful and productive learning experience. A bad day, to be honest, would look like something like, you'd be stranded on the ward, not doing much because, all your colleagues is out in theatre somewhere and there's no more slots for you to go, or there's no clinic ongoing, not enough cases for you to see, and you just feel like, you're a waste of a space there throughout the whole day. So that would be sort of my bad day. Occasionally you get really busy days that you have to go home an hour later than your designated working hour, but sometimes counterintuitively you feel really you feel the sense of achievement when you make a difference in somebody's life. So I wouldn't call that a bad day. It would just be a stressful day, but you learn something out of this on-call days. Mostly this happens during the on-call days when you're seeing patients and really unwell patients. Going to the next point, surgical training structure and application and selection processes. So in the UK, after you finish 2 of your foundation training, then you would apply for basic surgical training. It's called either the CST or the IST. So IST is something that it's an action to improve core surgical training, because we've identified certain limitations to the conventional or traditional way of training, mainly because there were too many time dedicated to service provision, not enough supervision, and you end up with a bunch of trainees who complain that they're not meeting their competencies in the first 2 years of their basic surgical training. And then they get all this, training gap when they are meant to be registrar in their 3rd year or, subsequent years of surgical training. So IST has certain criteria where they adjust your working pattern or working a location so that you get more training and more monitoring the 2-year program. So you get 2 years of basic surgical training, and it can include either 4, 6, or 12 months of placement in one specialty. So it's like your foundation placement. You get to choose different program or different tracks in either of the specialties that you're interested in. There are general surgery, upper GI, lower GI, hepatobiliary, your orthopedic sometimes, and urology, plastics, ENT, so on and so forth. And sometimes you get ICU or cardiac thoracic in the program itself as well. It depends on which trust and which programs that you pick. It can be coupled and uncoupled. Unfortunately, I think last year, they took up most of the coupled training program. When I say coupled, it means that you get the full 7 or 8 years of contract where you are destined to commit to one specialty already by your first year. So it's a run-through program. That means that if you wanted general surgery, then throughout the whole year, the whole 8 year, your training would be designed to cater you to your to general surgery. Uncoupled means that you will have to go through selection process again to get the national training number after 2 years of your core or improving surgical training. And it's more or less the same thing that you have to go through to obtain the CST or IST. It's just more competitive this time. So just a brief introduction to ST3 selection. After you finish core surgical training, you will be expected to assess your portfolio and interview for the national training number. And then after you finish your higher surgical training, then you will have your certificate of completion of training. Or sometimes people go down the parallel pathway, which is the Caesar pathway, where you get less supervision and no sort of routine ARCP, but instead you get like an appraisal every year to make sure that you meet the competency as your what you meant to achieve in CCT. I will answer further questions if there's anybody who is interested in knowing the details about this. Application process for core surgical training or IST starts in November every year. So this year it'll be November 2022, and you apply it through OREO, like how you apply through your matching in foundation training. You will be asked to give a self-assessment score according to certain criteria. All the documents are available on OREO, or if you Google it, I'm sure it will be out there. And the application deadline would be start of December every year. And then from December to January, you will be asked to submit portfolio evidences in the form of soft copy, letters, certificates to back up your self-assessment score. So an assessor, which is normally a consultant surgeon, will be going through your PDF uploads on a designated website, and they will verify your score and then give you either a new score or the same score that you've given yourself, and thereby you going through long listing and short listing in the process. And if the verified score meets the benchmark for invitation to interview, then you get you get a slot to pick for your interview, which normally happens between January and March. That is if you meet the benchmark score for the interview. And then the interview will happen. And then if you happen to be eligible for appointment, and then you'll be invited to rank different programs, and the matching process will happen. And if you get the job, then congratulations, you will know it by April normally. In 2021, there were 607 posts, and the competition ratio was 4.16, which was rather high as compared to the previous year. And recently it's getting more competitive for now. Selection for CST and IST. So what do they look at for portfolio or self-assessment scoring? So this is the latest one last year. They look at your commitment to the specialty, where you have to complete and pass your MRCS Part A to get the full mark, attend a few surgical courses, and it has evidence for it, and then go on to elogbook.org. It's a free registration process where you just get a accredited logbook online that you can lodge all your theatre experiences, where you scrub in either as a medical student or a junior doctor or a fellow. You can attend surgical conferences, and it gets you marks for last year. So there might be a bit changes every year, but more or less the outframe is as follows. Surgical elective and placement gets you a few marks as well, whether you're a medical student or an FY1. But I think they take into consideration over the past few years, there were lack of opportunity to do electives, so they have been a bit flexible with that. Postgraduate degrees or qualification or additional degrees gets you some score as well. If you have prizes or award from your medical school or regional international conferences, then those will get you some marks as well. Quality improvement or clinical audit project, it's mainly you just need one, but I would suggest to go for a surgical theme and a good one if you can during your FY1 or FY2 year, because you will have to do one as part of your ARCP assessment anyways. Teaching experiences, you will need feedback for that. You will need committed teaching, I think, for at least a few months' time, rather than just occasional teaching without any evidences. Training in teaching, it looks at short-term or postgraduate diploma course in teaching that will earn you some marks in that aspect. Presentations, regional, local, nationally, publication as well. And last but not least, some medical or non-medical leadership posts for at least 6 months. And you have to demonstrate that you made an impact. Normally, you get this evidences through a letter signed by your consultant. So the tip here is to gather your evidence early, rather than by November or December, just so that you have everything ready to go rather than scrapping through the last minute. It can be a bit annoying going back to your consultant when you've worked a project with him or her a few years back, because some of them won't be able to remember. So always gather your evidence as you go, even when you're starting out first year medical student, if you're keen on surgery. So this is for interview. So the interview format is a 20-minute online virtual interview for the past 2 years. It used to be face-to-face, but nowadays I think they appreciate virtual interview more, just so that they can get more capacity, so more people can go through the interview stations. So the format is very similar over the past few years. You get a management station, which is 10 minutes, and you get the clinical station, which is 10 minutes as well. So in the management station, you are expected to deliver a 3-minute uninterrupted presentation, normally on the leadership topic. So they want you to talk about how you demonstrate leadership and how you can apply leadership in core surgical training or IST. In 3 minutes, and then they will follow this up with 2 minutes of Q&A session. After that, you will be given a question, and the whole station is 5 minutes, mini station is 5 minutes, where they will give you a pretty difficult scenario. There's no right or wrong answer to the station about, management, leadership, ethical problems sometimes, and you are expected to answer, and they will have question that follows up to see how you react and how you present yourself. Clinical stations are pretty similar to OSCE stations, but just verbally. So basically, these are mainly acutely surgically unwell patient, or ATLS station, or sometimes just simple ABCDE stations. So these are the ones that we are more used to. Answering, just 5 minutes, very similar follow-up questions, and they just want to see how you manage in those sort of emergency scenario. So altogether, for the management and clinical stations, you will gather 144 marks altogether for the full marks, and that will add up with the 72 marks from your self-assessment or your portfolio station score. And then altogether, you will get the score to rank and match to your desired program nationally. So normally you get to rank the post nationally to Wales, Scotland, England, and Northern Ireland. Ireland itself has a separate system, so it's a different matching system. So how to prepare as a medical student or junior doctor? So these are a few suggestions. So when you are a medical student, take advantage of your surgical placement. Ideally, expose yourself, introduce yourself to everybody on the ward, and then attach to, your favorite senior or consultant, even better. And then try to get some projects out of the placement, because it will be very helpful. It can be as simple as a simple audit, one cycle audit, or you can go for, QI projects and collaborate with seniors if there's opportunities. But being proactive is key. When you are an FY1, it's always, there's always opportunity to opt for surgical placement, and you can work, with your surgical trainees, core surgical trainee, IST, or your registrar on some projects as well. Study for MRCS Part A and Part B. It's always not too early to start your MRCS revision. Obviously, your finals take priority, but if you finish your finals, you pass your finals, and you have some spare time, it's always recommendable to start revising for MRCS, because my personal experience, there is very little overlap between undergraduate teaching and MRCS, and it is a challenging for some. So you can take, it's recommended out there, you take at least 4 to 6 months to study, but I feel like that's intense studying, and it's even more difficult when you start working. So use your time well as a student, and you can start revising for your Part A when you are in your, like 4th or 5th year, depending on your university's commitment. It's not too early to start your Part B once you've done your Part A. And I feel like the continuity of studying from Part A to Part B gives you an advantage if you're committed to surgery. And I do know people who pass their Part B even before starting surgical training, and that's possible. And that would give you much more time to do something else during your condensed 2 year of surgical training. Find a supervisor, shadow a supervisor. The idea is to train yourself as a consultant, and you can do that even when you are, like in your foundation training, if you have time. But normally, surgical department, it's very busy as a foundation doctor working in a surgical department. So I could understand that. Audits, QI projects, research journal clubs, and anything academic. Expose yourself. Go and see how people do their project, listen, talk to people. When I started out, as a medical student, I didn't know how to start these projects, but it's very helpful to attend conferences because you see how people do, in their own ways, and you can learn from that, and you can sometimes, get a bit feedback yourself. You can manage some simple projects in your student selected components, SSC programs, and then you just find opportunities to present them. Courses can be helpful. There are certain courses that are mandatory in your surgical training, that being your basic surgical skills and your ATLS. The critically ill surgical patient course is not technically mandatory, but it's recommended, but that's a later stage. So just clear off your basic surgical skills and also your ATLS first, and you can do it right after graduation. I think maybe not ATLS, but basic surgical skills, you can do it right after graduation. It is a lot of money. You can ask around your foundation trust whether they have study budget for it, because I did got mine sponsored from my foundation trust. So some of them do sponsor, but if you haven't got it tick off by the time you enter core surgical training or IST, it's fine, because they normally sponsor for this mandatory courses as well. So it's up to you, the timing. It can be rather difficult to book onto courses during, a few months before, just because of the pandemic. But nowadays, it shouldn't be too hard to book onto these popular courses. Surgical clubs and society. So if your university has one, join it, just so that you get more exposure and practice on surgical skills, how to hold a needle holder, how to hold a forceps. And this can be very helpful in terms of boosting your confidence once you're in theater, so you know that you're not doing something that is not right. Start early, be proactive. I couldn't emphasize that more. If you want a surgical career, there's no other way. You have to be proactive. I can't recall any of my colleagues in the surgical field who are not proactive. And that's how we got there in the first place. Prepare for interview. Obviously, it stands for 2/3 of your marks, and that would determine your ranking to a matching process. Obviously, you have to take priority of your interview, so you can prepare it by the best way is to get a colleague who is also attending the interview, and then just practice with the colleague as frequent as possible. If not, if you have a very supportive senior, get them to give you feedbacks. And if all fails, just practice in front of a mirror or record yourself, especially, the 3-minute presentation. By the time that you will attend the interview, you need to make sure that you can memorize your speech back to back by heart, because you want to allow margin of error just in case you're panicking. So essentially, that's all I have for this presentation. These are the references out there. Most of the documents, most outdated documents would be on Oreo once they release they open the application. And you can check out some information online as well. So I welcome if there's any questions. Thank you.
Guys, if anyone has any questions, just put them in the chat box and we'll go through them. Kim, thank you so much for your talk. I actually have a question. Do you think by the time you get into core surgical training, you should have a good idea of what specialty you want to do? And if you don't, is there
That's a very good question.
Yeah.
Sorry, is there a way of?
No. Did you hear that?
I couldn't hear the last part of your question.
No, that was it. That was it.
Okay, right. That's a really good question. Should we have a clear idea of what we want to do before entering core surgical training?
Yeah.
I think there is good and bad, to be honest. So the good side is it gives you time to prepare and target your portfolio and your training towards a specialty that you're committed to, that you see yourself doing for the next 30 years. Let's say if you want to do general surgery, all your courses or your academic achievement and everything, it will be tailored towards general surgery, and you're not wasting time exploring around. But the risk of that is putting all eggs in the basket. So what happens if you go into core surgical training and realize that I might not want to do all the on-calls, I might not want to be called in the middle of the night, most of the nights, just to attend some general surgical emergencies. I might be able to do it at the age of 30. I might not be able to do it at the age of 55. So is that a lifestyle that is suitable for you long term? So a lot of the problems with the run-through programs they have realized is some of the trainees pulled up from the program, from the 8 years training program in the first or second year, just because they realize that, that specialty is not for them, and they see the good in, other specialties like ENT or plastics, which has less demand for on-call long term. So there is good and bad. However, on the other side of the argument is if you go into core surgical training not knowing what you want to do, you might be stuck in the limbo after the 2 years of your surgical training, whereby you couldn't get the number, then you have to get non-training post or take a gap year, and then some specialties do penalize you for taking more year out of training, and the most renowned one would be general surgery and ortho so far. So there is risk whichever way you go. But essentially, I think you want to stay true to yourself. And if you feel like you're not committed to any of the surgery, you need to explore around. You need to use out your taster weeks to go to different specialties and see how a consultant's working life is like. You want to see the consultant's working life, not as a trainee, because if you can't see yourself as a consultant, don't be a consultant. Don't waste 8 years of your life training to be a consultant.
Absolutely, thank you. We got another question in the comments from Alyssa, who's asking you, how is your work-life balance?
So work-life balance as a trainee is not as optimistic as some of my friends in other specialty, I would have to say. You are expected to cover on calls, and you are expected to do service provision, even though they have introduced the IST pilot program a few years back. My rota, depending on the department, so far I have been on 100%. I'm working in Scotland, so I've been on 100% banding so far. That means that we are working exceeding what's recommended. And it's a busy department, to be honest. I would have a period of time where I'm working nights every 2 weeks. And then every night shift would be 12 hours shifts. And then most of the time, if I'm not working nights, I'm working 12-hour shift daytime as well during the on-call 6 weeks period. Then you will have another 6 weeks period where you would just focus on your training and you're working, my personal trust words, we work 10-hour shift on a short day. So those are the training opportunities. So it is quite vigorous, and it doesn't get better when you're a registrar. The registrars covers the on-call, and the demands for them are even higher than us SHOs. So the coming 8 years would be gruesome, lack of work-life balance, if I'm being completely honest, as a surgical trainee. But I would know somebody who would, say otherwise. So this is just my personal opinion.
Thank you for that. So we've got another question. Can you please explain the concept of uncoupled aspect of the surgical training structure? Slide again.
The uncoupled aspect of surgical training, it's basically just the difference between coupled and uncoupled training is mainly just whether you get a 2-year contract or a 7 to 8 year contract for your surgical training. So the CST or IST itself is a 2-year program. If it's uncoupled, it means that you will have to undergo selection progress, meaning, the whole selection, going through oral again, and then showing your portfolio, going through interview again. By the time you are in the middle of your 2nd year core surgical training or IST. So you will have to go through a selection process again. Whereas a couple program means that you don't have to go through the interview or the portfolio a 2nd time. You have a number already. It's a run-through program. So once you get the 1st year, it's a contract for you to train 7 years or 8 years until you are consultant. But unfortunately, last year, they pulled out most of the run-through programs from England. And the only ones remain, the run-through ones that remains, are the ones in Scotland. And then I think there were only around 10 run-through posts last year. I don't know what will happen this year, but I would imagine it's very similar this year time.
We've got what are your average number of working hours per week?
So it varies. So when I'm on a training rota for the 6 weeks, I would work 10 hours, 5 days. So Monday to Friday, 10 hours. So that's around 50 hours per week. And you get to clock in, clock out, go in at 8 and then come out at 6. So life is good. You get the weekends off. When I'm on an on-call rota, then it would be sometimes I do work 70 to 80 hours a week. Unfortunately, you do get a very cruel day working rota where you have to work 7 days continuously, and you can shift into day and night the next day. It can be very, very tiring during those periods. And like I said, it doesn't get better when you're a registrar. It only gets worse.
Last question is your experience from a general surgery themed CST?
So, my program is kind of it's not a typical general surgical theme placement. So I spent my first 6 months in vascular surgery, then going into general surgery, and then going to ortho, and then general surgery again. So it's not a typical general surgery theme placement, but it is what I opted for. And the placements in Scotland and England varies. I do know in England you get to do, it's very normal, it's common for you to get general surgical placements and then going to ortho and then going to other unrelated, less related specialties. But some of the program is very nicely designed where you get, if you are interested in plastics, then they would give you like ENT placement and plastics and then something very relevant to your interest. So my main interest is general surgery. So I would say yes, but it's not just general surgery. It's a bit trauma, a bit, vascular. So it's a pretty exciting program in my opinion.
Thank you. And Terry's got another question. Do we rank nationally, or do we have to choose England versus Scotland, or etc., for example?
It's a list. You rank everything together. You rank the jobs between England, Scotland, Northern Ireland, Wales. So you rank them. You rank all 600 jobs in a go.
Okay, I think that's all the questions. Kim, thank you very much.
No, thank you.
Perfect, guys. Thank you all for attending. I think you'll get a um, you'll get an email asking you for feedback, and then you'll get a certificate as well. If there are any issues with that, just drop someone in online, leave a line on Facebook or something. Okay. Thanks everyone. I'm going to shut off the presentation.
Okay, that's. Yeah, thank you.